Unit 10, agents to control blood glucose and drugs acting on the endocrine system. First, we're going to be talking about diabetes. So diabetes is basically a condition wherein the body has a sustained levels of hyperglycemia. So this is when our serum glucose levels are staying above the normal range. So this is not a side effect of something else. So when we say diabetes, there's no other reason for it, right? There's nothing, maybe, they took a medication to increase the blood glucose. No, that's not it, right? This is a condition that's developed without the influence of other things or medication, and the blood sugar stays up. The classic symptoms of diabetes will be your 3 P's: polyphagia, polyuria, and polydipsia. Polyphagia is excessive hunger or eating. Polyuria is excessive urination, and polydipsia is excessive thirst, causing a patient or a person to drink a lot of water. These patients will also display signs and symptoms of dehydration. They may experience weight loss, glucosuria, or basically glucose in their urine. It does affect their vision, so you will see many diabetic patients, especially if their blood glucose are not under control, they may develop blindness. You will see that they have a hard time healing, especially if they have an open wound. It does lead to neuropathy because it's sugar is very damaging to the nerves, and many of our patients will develop impaired kidney function. Let's discuss the differences between type 1 and type 2 diabetes, as well as diabetic ketoacidosis. So type 1 diabetes, also known as insulin-dependent diabetes mellitus, this is basically caused by autoimmune. Usually it can be hereditary, it can be secondary to a viral infection, thus affecting the function of the pancreas, or pancreatic trauma. So in this case, the pancreas does no longer produce insulin. And so what happens is, because the pancreas does not produce insulin, then we have to give the patient insulin so that it can utilize glucose as a source of energy. So that's why it's called insulin-dependent diabetes mellitus, because the patient will have to depend on insulin. In addition to insulin, they need to modify their diet, and obviously they need to maintain a certain level of physical activity. Now, in this case, DKA is quite possible, especially when they are acutely ill. You will see that patients who otherwise their diabetes is somewhat well controlled. Sometimes if they end up with another disease process in the hospital, they have a severe infection, they end up with DKA or diabetic ketoacidosis. Now, type 2 diabetes, on the other hand, is also known as non-insulin dependent diabetes mellitus. So this is usually caused, can be hereditary, can be caused by obesity, pancreatitis, and poor diet. But in all honesty, most of the time, it's really because of their lifestyle. So it's not always hereditary, because when you say, oh, hereditary, mom and dad had it, cousins, or so on, right? Many of the family members have it. But if you really examine closely, their diets are about the same. Their lifestyle is about the same. So this diabetes is usually secondary to poor lifestyle. So that includes poor dietary intake, lack of physical activity, and so on. Now, in this case, typically the pancreas still works. Sometimes it may not have enough insulin, especially in comparison to what they're consuming, or sometimes the body is just not reacting or producing insulin appropriately or at the right time. And so if dietary fat intake is excessive, the pancreas may actually be unable to keep up with the demand, and it may not be able to produce enough insulin to use the carbohydrates. Now, in here, it is important to change their lifestyle. So modify their diet, make sure they're increasing their physical activity. But again, in addition to that, they have to typically be on some medications, either it's oral anti-hyperglycemic agents. Unfortunately, although we don't typically start them on insulin, many of these patients, if they don't control their glucose levels, And so if we want to prevent further complications, these patients may end up being put on insulin. The good thing with these patients, they are not usually prone to DKA. I'm not saying that they're never going to develop it, but they're not as high risk in comparison to the type 1 diabetics. Now, talking about DKA, what is DKA? DKA is diabetic ketoacidosis. So this is when not enough insulin is produced. Therefore, the glucose levels are out of control, leading to severe hyperglycemia. Now, when there's an elevation of blood glucose in the body, and our body is unable to use that glucose for energy, what happens is your body has to resort to something else, and that would be fat. So it will try to use fat as a source of energy, and what happens after being metabolized and used as energy, the byproduct of fat is ketones, leading to ketoacidosis. The byproduct are keto acids. Now, patients that have DKA will have signs and symptoms of severe dehydration, and they will have electrolyte imbalances, mainly your potassium. Unfortunately, when a patient has DKA, they're very sick. They typically end in the ICU, and if we don't act fast and if we don't control their glucose levels, it can lead to seizures, coma, or death. All right, the opposite of hyperglycemia is hypoglycemia. So hypoglycemia can be more dangerous than hyperglycemia because in hyperglycemia, typically the symptoms and the effects are more gradual. So it takes time, but if a patient's blood glucose levels are really low, they can acutely deteriorate. So symptoms would include shakiness, weakness, fatigue, hunger, sweating, nervousness, confusion, lethargy, seizures, and coma. So depending on their age, so especially in children, they may be unable to express how they're feeling. So you may notice that they're just more irritable or lethargic. And so with hypoglycemia, it is very important to talk about hypoglycemia because many of the medications that we use for diabetes, they have a side effect of hypoglycemia. So that's why it's very important to know, the signs and symptoms and the potential complications of hypoglycemia, as well as how to treat it. Anyhow, so when a patient is hypoglycemic, it is very important that we act fast. Usually, if we have access to it, if they're awake enough, then we can give them some cranberry juice and followed by some complex carbohydrate and protein so they can kind of keep it. Cake mate can be used at times. Now, in the clinical settings, there may be some glucose tablets as well as if the patient is unable to ingest anything because they're too lethargic and they're at risk for aspirating, then we may have to give them glucose through the veins via an IV D50. Make sure though that we don't overtreat. So when we give the patient something to increase their blood glucose, we can't keep on giving it to them without really checking the blood glucose. And remember, it will take about 20 minutes after ingestion of something of glucose before you start noticing the effect. The problem is if we don't monitor that and we're kind of impatient, we may drive the patient's glucose levels really high. And so it's going to have a yo-yo effect. And actually, that can cause more complications for your patient because you don't want a blood sugar that's really low and next thing you know, it's at 400, right? So make sure that you're rechecking your glucose levels, be a little bit more patient, unless, of course, if you see the patient is, deteriorating quickly. But usually it takes about 20 minutes before you start noticing the effect of your treatment. As mentioned earlier, hypoglycemia is basically a state of low blood glucose levels. So generally speaking, that is when a patient's blood glucose level falls below 70 milligrams per deciliters. So again, signs and symptoms of hypoglycemia includes confusion, irritability, tremor, sweating, hypothermia, and seizures. Complications, if it's not treated properly, it can lead to coma or death. Now let's turn your pages to page 10. drugs acting on the endocrine system. So let's talk about the thyroid hormones. So you have your T3 and T4 and calcitonin. So these are hormones produced by your thyroid gland. So T3 and T4. T3 is basically the active form of thyroid hormone, and T4 is the inactive form. So it helps in protein and carbohydrate and fat metabolism. So this is basically, it kind of regulates a patient or a person's metabolism. It has chronotropic and inotropic cardiac effects. So when we're talking about chronotropic and inotropic, chronotropic, it actually influences your patient's heart rate. So we're talking about the rate when we say chronotropic. Now, inotropic is the force of contractility. So again, your thyroid levels can actually affect how effectively your heart is going to be pumping. So knowing that, we know that thyroid hormones can affect your heart. Now, it does affect red blood cell production as well as respiratory rate and respiratory drive. Calcitonin, on the other hand, although it is produced by the thyroid gland, it actually has a whole different set of role in our body. So calcitonin is a hormone that increases bone formation, therefore decreasing serum calcium levels. So what it does is it basically gets the calcium from the circulation and back to the bone, therefore helping with that bone formation. Now, when we say a patient has hypothyroidism, we mean that this patient has low levels of thyroid hormones. So hypothyroidism can be primary, it can be secondary, or tertiary. So primary is the most common type of hypothyroidism. So in primary hypothyroidism, typically when you draw their blood work, their thyroid stimulating hormone or TSH is going to be high, while their T3 and T4 will be low. So TSH, thyroid stimulating hormone, is basically a hormone that is produced whenever our body's thyroid levels are low. It's kind of like your regulator, and it says, oh, it's low, I'm going to be replenishing it with more thyroid hormones. On the other hand, if a patient has secondary or tertiary hypothyroidism, when you draw their blood work, their TSH and their T3 and T4 are all low. So it's low across the board. Now, common causes of hypothyroidism includes Hashimoto's thyroiditis, drugs such as amiodarone, pituitary dysfunction, and iodine deficiency. And another secondary cause of hypothyroidism would be a patient undergoing a thyroidectomy. So it can be either partial or full thyroidectomy, which causes either a decreased production of thyroid hormone, or when you don't have a thyroid gland, then you're no longer producing thyroid hormones. So signs and symptoms of hypothyroidism includes weight gain, cold intolerance, dry skin, fatigue, and weakness. Now we're going to turn our page to page 11, and let's talk about hyperthyroidism. So that would be the opposite of hypothyroidism. Hyperthyroidism, on the other hand, is the excessive levels of thyroid hormones. So typically when a patient has hyperthyroidism, their TSH will be low, their T3 and T4 will be high. Common cause is Graves' disease and thyroiditis. Signs and symptoms, so that would be the opposite, right? So think about it. So the thyroid hormones, they're responsible for metabolism. So now you have too much of the thyroid hormone. So what happens to your metabolism? It gets faster, right? And so in hypothyroidism, you'll see that most of your patients will experience weight loss, heat intolerance, tachycardia, and for some patients, they will have exophthalmos. So exophthalmos is basically the bulging of the eyes, secondary to excessive thyroid hormone. So this is very, when you see one, you're never gonna forget one. Like I said, it's really bulging out, and for some patient, when it's severe, it looks like their eyeballs are literally popping out of the socket. All right, now we're in page 12, parathyroid hormones. So parathyroid hormones, they are secreted by the parathyroid glands. So parathyroid gland is actually, they're like little glands in the thyroid gland. So it is pretty, they're pretty small. And sometimes if there's something going on with the thyroid, they can be affected as well, just because they're attached to the thyroid gland. Well, anyway, parathyroid hormones are separate though. They have their own function. Now, again, it's secreted by the parathyroid gland, and usually the parathyroid hormones are secreted in response to low serum calcium levels. So parathyroid hormones help regulate calcium levels. So what happens is parathyroid hormones can cause the reabsorption of calcium from the bones. So we're now stealing it from the bones to the serum, to the blood, right? Because the blood levels are low. We need to have a constant balance, right? Usually, if it's too high, we want to put it back to the bone. Now, if we don't have enough, we have to get it from somewhere, and typically, it's being obtained from the bones. Now, in addition, parathyroid hormones causes an excretion of phosphorus. So something that you have to remember is that phosphorus and calcium had an inverse relationship. So if you have high phosphorus levels, you will have low calcium levels in your blood, and then vice versa. So if you have high calcium levels, typically you'll have low phosphorus levels. Anyhow, so parathyroid hormones will actually increase serum or blood calcium levels. Now, some patients may experience hypoparathyroidism, which leads to low calcium levels or hypocalcemia. So this is when a patient does not have enough parathyroid hormone. So a common one would be a complication from a thyroidectomy. So like I said, the parathyroid gland is attached to the thyroid gland. So then if somebody gets their thyroid taken out, unfortunately, sometimes the parathyroid hormones cannot be saved. They can be damaged. So that leads to hypoparathyroidism. Anyway, so like I said, it can lead to hypoparathyroidism, therefore leading to low calcium levels or hypocalcemia. And what happens, again, there's an inverse relationship between calcium and phosphate. So what happens is when calcium levels go down, then phosphate levels will go up. Signs and symptoms include tetany, numbness, osteoporosis, right? Because we're taking calcium from the bone now. And when you're assessing your patient, you will note positive Chauvet and Trousseau. So Chauvet is actually like spasming of the cheeks, and then Trousseau is the spasming of the wrist or forearm. I'll probably show you guys an image or a video in class, and that way you kind of have an idea of what it looks like. And so if you see it, right, you will be able to identify it on your patient. Now, there are some agents used for hypoparathyroidism. So when you think about hypoparathyroidism, the main problem with not having enough parathyroid hormone is we don't really care that the parathyroid hormone is low. The problem is it leads to hypocalcemia, and we know that calcium is very important for our body and for us to function. And so anyway, so how do we treat hypoparathyroidism? Then we have to treat hypocalcemia, right? So what can help increase your calcium levels? Well, one, vitamin D supplementation, because we know that that's going to help with calcium levels. In addition to that, calcium supplementation. You have low calcium levels, guess what? Then you're going to need calcium supplements. In addition, obviously, as a nurse, we have to assess for signs and symptoms of hypocalcemia as well as hypercalcemia, because sometimes we can overtreat. So anyway, so that's hypoparathyroidism. Next, we're going to be talking about hyperparathyroidism, which leads to high calcium levels. So again, hyperparathyroidism leads to high calcium levels. So this is due to too much PTH, leading to hypercalcemia. And remember what happens with phosphate, right? Now that our calcium level is up, your phosphate levels go down. And typically on a patient, you will see bone calcification, right? There's too much calcium, and because of that, sometimes we have so much calcium circulating, and guess where else it will circulate? In your kidneys, because the kidneys are responsible for filtering things, right? And so these calcium deposits, right, start happening, causing renal calculi or kidney stones. Anyway, we're going to go over the treatments in class. Hopefully this helps understand the different endocrine disorders and why we're treating them the way we are treating them with certain medications.